and then we're going to do the bottom. So it's 7 minutes each direction, 7 minutes face to face, 7 minutes face to feet. I'm going to start on the top of the foot. We have our tibia and fibula right here. And right where this bend is, right in the midsection where that soft tissue is on that ankle, if you just kind of touch as we bend, it's a little softer, but there's a lot of tendons and ligaments. But that is your talus. So if somebody was just complaining about an ankle issue, and once we get to the last day and I show you one-shot therapy, you can release majority of ankle problems just with the shot glass or like a gouache stone. So we have the talus right here, that soft tissue. I'm going to work into that talus. This is my focus point for the top. We have medial malleolus on one side, we have lateral malleolus on the other, and then we have like that anterior talofibular ligament, and that's all kind of tucked in within here. We have the tarsals, which are these bones right in here. The tarsals are kind of closer together, and as they come down through the metatarsals down here, they start to separate a little bit. So when I'm working the top of the foot, the bones are closer together, so you're not going to feel like you're in the pathways as well. But as I start to work my way down, my elbow kind of sinks into the actual metatarsal, and so then I'm cleaning out each pathway of the toes. By doing that, it's a meridian to help stimulate lymph drainage, so it also can be a super sensitive area if the person's pretty toxic. The feet are generally pretty sensitive in general though, because gravity pulls circulation down, has a hard time getting out, so the tissue's a little toxic. I'm going to start face to face, and we're going to do the top portion of the foot, starting 2 inches above on the tibia and fibula. I'm going to scale my way working down, and I'm going to focus in that talus, that soft tissue right here. Spend about a minute and a half here. After I work that talus a little bit, I'm coming up over top of the tarsals, and I use my guide hand to kind of keep me in line with each metatarsal once I get to it. So I work the tarsals. Then I start to come down through each individual metatarsal. I work my way down and back up, down and back up, down, back up, down, and back up. After I've done the top of the foot and through the metatarsals, this is where we kind of call it like the hot dog bun, hot dog technique, but I'm technically just taking 2 fingers. It makes more sense when we do hands, and you're going to learn when we do fingers. It's the same thing. When we're working on the phalanges, I'm just taking my fingers, depending on how small their toes are, like especially when you get to the pinky toe, like it's literally just like 2 fingers or 1 finger underneath supporting it. But I can still place my elbow directly on top. And like I have a bigger elbow than all of you because I've recarved it and it's taken time to build up. But I'm still directly on that little pinky toe. And you're like, it's so small, but you can still work it. I'm just isolating and staying in control. And there's not a lot of tissue depth, so you feel everything. So after I did tibia and fibula, I did the talus. I came over the tarsals and through each metatarsal. Then I isolate the toes.
Are you on top of those or between them?
In between, once I'm on top at the top. That's where I was saying the tarsals are closer together. And then as I kind of fall down into the metatarsal, I fall into the groove. So after I do each metatarsal, I'm isolating each individual toe, and I'm going to touch on the individual toes. If somebody has hammer toes, you're going to want to get a shot glass, and hammer toes is when they're kind of like locked in like that, and they're stuck. You're going to want to get a shot glass, and you're going to go in and really work those knuckles. I will show you guys how to do that on the very last day. After I do each individual toe, from face to face, flip myself over, face to feet, I'm naturally going to go to the medial side because her leg can out-rotate like so. I don't want to be working on it like this though, where there's tension pulling. So you're just going to take a bolster and slip a bolster in that knee to support it. This is perfect for me. After I finish that top portion, I'm only staying here right now to explain it to you guys, but after I finish that top portion of the foot, when I did it from face to face and face to feet, I would technically be face to feet right now, starting on this medial side. So when we go to the medial side of the ankle, we are working around the ankle bone, the medial malleolus, coming back to the Achilles tendon, down to the heel, and out along the spine of the foot. So following that arch, all the way to the big toe. I'm going to do that from face to feet and face to face. So we always start 2 inches above near that tibia, and I'm working down around the medial malleolus, back to the Achilles tendon, and it's an outside to inside work. Some people always will come around the backside to here. It's not like there's a right or wrong, but there's just like a method to it. So I start on the outside, I work to the inside, then I come down to the heel, then I come out along the spine of the foot to the big toe. Face to feet, face to face. Now I'm going to rotate her over to the lateral side. And so she's going to go all the way onto the hip. That's perfect. If I notice that this was tension, if she's fine like that, that's good, but I can just take this bolster, flip it over, tuck it right in so it's nice and supported. When I'm working this side, technically I'd be finishing face to face when I did that medial side. So now I'll be face to face, and we're doing the exact same thing. So it's the same when we did the knee on either side. It's the same thing. So I'm starting 2 inches above, working down around the lateral malleolus, back to the Achilles tendon, down to the heel, and out along the spine of the foot to the pinky toe. I'm going to do that from face to feet. And then I'm going to flip her onto her stomach in prone position, and we're going to really work that Achilles tendon, heel through the bottom of the foot. But if we're so far so good with the direction, I'm going to show you the tops and the sides before I flip her over. So far so good.
So 2 inches above there, and you come down around through the arch of the foot to the little toe. Do you want to come back up the side of the...
If you have time, yes.
Oh, okay.
If not, you're going to do it again when you flip over anyway. So if you're within the time, and I've already worked all the way around, like I say though, guys, remember I'm teaching you so cookie cutter. I'm doing everything like at least do one direction. My clients, I push them quite a bit with their pain threshold, so I can't stay in an area too long. So I will get through the routine that you guys are doing like 3 to 4 times within each treatment, because I come back to the area. With this, you're still learning, you're not too sure, so I'm getting you to be really thorough and at least do everything once. But if you got the time, girl, just go back and forth, strip it. So after I do that lateral side, then I would flip her over into prone, but I'll show you guys that once we get there if that's all good. Okie dokie. I'm going to take a bit of that coconut oil. This one's giving me a little bit of trouble. And so, coconut oil, clean hands, nice and warm, beginning with a nice airplane landing effleurage massage. And when you're doing it, guys, the ankles take a beating. And like you don't realize the like freedom you're gonna feel after this because you're on them all the time. You don't really care about them, we don't cater to them at all. But they get over time, and things are such a slow progression. Like you don't just overnight, oh, my ankle's frozen, it's shit. No, it's taken time, and you don't realize the lack of mobility each joint has. And so if you do a really thorough ankle today, you're gonna wanna get the other ankle worked on the revite because you're gonna notice like everything feels like super light on that foot. So when I'm doing feet though, especially with my effleurage massage, because the elbow is sensitive, make sure you're putting pressure on. Like it's not just like, like I'm going through, I'm using my thumb to push along, I'm softening that tissue. And you know what? A lot of people afterwards can feel a little sick too, because this is the area for reflexology. And so you're elbowing every single point. So they can have like different things happen to their body afterwards just from working the feet. All right. If I noticed, like even Simran though, like so we've been talking, we've been working on this a little bit, but she's starting to get a little bit of a bunion here. See how this toe is starting to bow out? That joint is getting displaced calcium here. It's getting too thick. So she's needing to take a glob of the DMSO gel, put it on her toe, put a Band-Aid there, and go to sleep for the night. Do like people like clap them really thoroughly, but shot glassing is going to be the best because it'll actually like break up more. But in general, like any kind of like bone spurs, hammer toes, bunions, such like that, you want the DMSO gel. And you want to be doing like packs every couple nights on top of it as you're sleeping because it's going to stimulate a lot of circulation to go to the area to at least soften it. Because if I want to try to break this down with my elbow, it's going to really hurt my elbow. And then so monitor the things that people have. Don't wear yourself out. Try to get them to do some of the therapies themselves. Teach them. Instead of charging them to come in and you're going to just destroy your elbow, trying to just focus on that bunion if they have something really severe. Teach them how to be super thorough and go home and just push themselves with the shot glass. because then they can be doing this stuff at home to themselves on a daily basis, every other day. If it's a little sensitive and they work too hard, give it a day or so rest. But it's really necessary that you're not trying to heal the person, they're wanting to heal themselves, so they're taking massive personal action. Cell-sonic would be great. Yeah, and then do the treatment, because any kind of calcification, bone spur, something like that, cell-sonic first, then after. If it's a surgical scar, go in with the non-surgical and then cell-sonic it, so it gets into the cells a little deeper.
So just daily maintenance, can I cell-sonic, put the Band-Aid on, and the DMSO and go to bed?
Totally. That's going to be like daily maintenance. I would only maybe do the cell-sonic every like 4 days or every 3 days at that point, because if you're really adamant about it, and people like, because most people don't hydrate properly, most people don't like to exercise too much. When people do the cell-sonic, it is an expensive treatment. And so I make sure, I say, hey, over the next few days, try not to waste, because money's more important for people than health is sometimes. So you're gonna be like, hey, don't waste your money. The pulses can stay alive for up to 9 days. They diminish a lot. What? Oh, yeah. So, but the thing is, you don't hydrate properly. What are your cells made out of, remember?
93% water.
7.
What?
97% water. Yeah, so it's almost completely water. It's almost completely water. So if the cell-sonic deals with this, yes? In one treatment or in total? You can get rid of a bunion. You can get rid of it. But in one treatment, sometimes you don't even see a difference. Their bunions will come back.
Yeah.
They will come back. Because it's literally just, so why does a bunion happen? What is it? It's calcification. What is calcium? Bones. So why is the bone just growing? It's impossible. The bone doesn't just grow. So your body has to take calcium from the surrounding areas. So I'm losing calcium from my tib and fib, maybe some of my tarsals, my metatarsals, to take some of that. That's why when people have osteopenia or osteoporosis, they start to get those big holes within the bones. That was the calcium that is now binding over top of here, because the foot was slightly deformed and it was inflamed, and so it was having to buffer down that inflammation by layering it. So it's going to take some time, but you can get rid of it.
What about flat feet?
That's going to be when we get to the arch and we carve out the arch. A plastic? Spastic foot, yeah. I would also, though, I would start from his like pelvis area, and I would do like pelvis, hip, knee, and ankle foot.
So working around that, because again, you can't
You'll be able to get him to bend it.
So do you do this treatment on?
Yes.
Can I just ask you about those flat feet? I know a young person that wants to operate that part. What is that actually? Like,
Flat feet.
yeah.
It also could just be like the structure of their bones, though, and they're not like walking properly. Maybe their pelvis or their hips are a little bit off, causing one foot to be a little bit more flush than the other. There's a lot of different things that can play a role in that. And then it also is just like sometimes you're born with a little bit of that structure, but over time, since it's abnormal, your body has to overcompensate. So it doesn't like the way that it's the sensations that it's feeling while you're walking or doing your daily routine, or what he's doing. Maybe he goes to the gym, plays soccer, I don't know. That the body has to fill that in, because it's like an inflamed area for itself. So it's almost thinking, these things that your body's doing is thinking it's protecting you. Yes, it kind of gives you like more ailments down the road, but right now, you're on fire. It does not like what's happening. So it's like a protection thing. So it's kind of like your body's way of defending itself.
So it can be.
Oh, you can totally recarve it out once we flip her over and I explain how to come through the bottom. Oh yeah.
You did? So one last question about the corns, bunions. You know, a lot of people who work on their feet, like waitresses, that kind of thing, they end up with, it's the shoe. I always thought
It's shoes. It also is shoes. Yeah, and the same thing with what women, like, because women have like ridiculously high arches. Oh, I wore high heels for a lot of my life. I was a waitress for many years.
Yeah.
There you go.
So they need to change their shoes though, because you do the work and then they put the same shoe on. And
Correct.
Okay.
Yeah, you got it. So like, and like, look at that. When like somebody's coming in, like they're complaining about their feet, ask them, You got to question them and be like, okay, sounds good, we're working the feet. What kind of shoes do you wear? What do you do for a living? What kind of sports do you play? These are all questions that should be done when you're going over their case history. Because this is what you got to reflect back on, because it's not just one thing that's setting it off. It's not an end-all, be-all. There's going to be a lot of little things that are triggering it to start to kind of...
What about high arch you have to have, or thought?
Same thing. But I'd want to carve that out and get them really stretching that foot out. I'm going to teach them different feet exercises to stretch for that high arch. I'm going to get them getting like a foot roller, you know, those like wooden foot rollers. I'm going to get them rolling that out, softening the tissue. Like there's so many things we can do. Somebody comes in for an ailment with their shoulder. Why did you not look up some different shoulder exercises to stretch out their shoulder and show them how to do that? It shows you care. It's not like they come in, you're like, pay for the treatment, leave. I'm trying to teach people how to heal themselves. So if you have something going on, I want you to figure it out, but I'm going to help figure it out with you. And we're going to come together, and you're going to do all this work. You're going to do these stretches. You're going to do the clapping. You're going to stimulate it. You're going to do the non-surgical. And then it's all going to start to come together. Totally, because the ionic calcium focuses on getting that calcium back into the bones. So any kind of calcification, yes. Like how is it? Like what direction, how is it? Inwards, hips. There's a pelvic tilt because like some people it's going to be outwards, they're going to be like duck feet. Then there's some people are going to be like penguins, it's going to be inverted. So I would say hip more area, pelvis, low back, that'll start to turn outwards. It's not just going to be, well, I want to look at the body though, because you can see it. Like once you kind of get somebody like some of their clothes off, they're standing in their underwear, you'll see where their body's misshaped. So I can't be like, just coming from the ankle. What if I start to see when she stands like this? So then I know it's like, oh no, hip and knee, that's going to start to outturn. And then I'm going to be like, hey, when you're walking, you need to focus on outturning it because that's what your body's accustomed to. Like same thing, she's not here today, but with Christine. I'm constantly telling Christine, you got to monitor because she'll talk and she'll get like a little distracted and she'll like allow her foot to intern. It's like, no, you got to be aware of that. You got to force it out because you've been doing it for so many years. That's normal for you now. You need to make them abnormal, not normal, because it's not normal, but it's just what the body thinks is now. So, now Alice, coming over the tarsals and through each individual metatarsal, and then I'll do the toes. Flip myself around, pull everything back up. And mindfully, this is where I say, guys, use common sense. We know that the tendons and ligaments are inserting down and they come this way. We don't want to be coming too much face to side. It'll be like guitar strings and jumping over bones. It'll feel like a really weird sensation. I try to want to clean out pathways here. Windshield wiper is great. This is great. But too much to the side, this is going to feel pretty awful sensation for them. So I worked from the tibia and fibia. I'm in the talus right now. Hang out there for a moment or two. Little bit of windshield wiper. And then carving my way down the top of the foot. My elbow just came over the tarsals and I kind of just fell into the indentation right here through the metatarsal. In between. So here you're on top of the bones and then you fall in between. Yeah, those are very close together. So that's where I say you're kind of just on the top of the foot. I'm going to scale my way back up. Next metatarsal. Scale my way back up. Next metatarsal. And scan my way back up. And I'm going to come through that last metatarsal. And with my guide hand, I'm kind of just separating the toes to open them up a little bit more. Like as I was working down, my guide hand, my thumb was just kind of pushing the toes apart to open up those metatarsals a little bit more.
How many are there? Metatarsals? 4.
You're going to be in between 4 gaps, but there's 5 metatarsals in total because you have 5 toes.
If you have six toes.
You might have another one. But it's rare. Like the thing is, there's bodies out there that you're going to come against that you like. They're different. I work on the spines where there's 3 extra vertebrae. So it's like the body's weird. There's things that can happen, like things that you're going to come against. If you work in this general realm, you're going to see people being like, I've never seen that before. There's new diseases, new ailments every single day. So there's going to be stuff that I'll come up against something like, never heard of. So I cleaned out from the tibia and fibula, came down into the talus, over the tarsals, through the metatarsals. After I do each individual one, taking my fingers, tucking them under the toes, and I'm going to work on each of the toes.
On top, huh?
Directly on top. And I'm focusing, of course, at the knuckles. I stop at the nail. I allow my guide hand to tuck my fingers right under, and I isolate on top of each toe.
Beautiful. Beautiful. Very good.
Last little one, and see, it's a tiny toe, and I got a big elbow, but I can still work it. After I've done that from face to face, take a little break, flip over, and I'm going to go face to feet, and I'm going to do the exact same thing. So my face to feet is going to look like so. I'm going to tuck right in, and